Okay, so just a few more to go. The next one is seizure, and seizures are pretty straightforward. If the patient's had a seizure and they're no longer seizing, there's not a lot you need to do, except protect them in case they have another seizure, right? Because they could have a second seizure. And a lot of times these people get combative in the postictal state, so be aware of that, because you may have to use some restraints one way or another so they don't hurt themselves. But for persistent seizure activity, get an ACA check and give some Ativan. A treatable form of seizures is hypoglycemia. We have to know that. We can't let somebody with blood sugar at 22 continue to seize without getting an ACA check. You've got to do that right away. If the seizures stop, you get it under control, you check anticonvulsant levels. We can only check certain anticonvulsant levels. Dilantin, Depakote, Tegretol, phenobarbital, the typical ones we can check, and usually we can get those results back, the levels back, within an hour. But some of the other meds like Topamax and Keppra, those are send-outs. They're not going to help us in the ED. We typically don't draw those levels. You don't have to order anything else on these patients if the seizure is completed. You're done. It's a totally different world if it's a new onset seizure. That requires a workup, and that patient's going to need lab work, CBC, chem panel, maybe a drug screen, and the physician's probably going to get a CT scan, but that's not something you need to get involved with. Febrile seizure, just treat it like fever. Get the temp down, and if they meet any of the other criteria for ordering tests, they would do it. But there's no specific workup for febrile seizure in a child older than 8 weeks. Just get the temperature down. The doc will decide if there's a workup needed. Simple and straightforward for seizures. Sepsis. This is a big area of emphasis for all hospitals because the mortality rate with sepsis is anywhere from 35 to 70% from one hospital to another. And we know that early appropriate intervention really drops that mortality rate tremendously. So people in hospitals all over the United States are doing what are called sepsis bundles. And we need to get that started in anybody who's septic. So septic, there's several kinds of septic, but basically people have a fever and something else, such as their rest rate is high, or their heart rate is high, or they're altered. Those are septic patients until proven otherwise. And those people need an IV in them, and they need labs started right away. They need a CBC, a BNP, blood cultures, and a lactic acid. Does everybody understand why we draw lactic acid? I bet some of you don't. So lactic acid measures perfusion to the cells in your body. Septic patients typically are not perfusing well, so they start producing lactic acid. When we measure that, we're measuring how well the body is perfusing the cells. And if it's high, we know that that the patient is in bad straits, and we really have to aggressively resuscitate them with fluids. Some septic patients are down 4, 6, 8, 10 liters of fluid. So that grabbing that lactic acid really gives us a good idea of how bad their sepsis is, and it's not always apparent clinically. So you draw the lactic acid level and start fluid boluses. Now what we have in our protocol is you start a 250 cc bolus that could be repeated once. But beware. And you typically will see these orders. I want a 500 cc bolus. The physician will give me a 500 cc bolus repeated every 10 to 15 minutes until a patient's no longer tachycardic or hypotensive. And that may be liters and liters of fluid. You may not feel comfortable with that, but that's the way you adequately resuscitate them. And we follow it with a lactate level. Every hour or so, repeat the lactate level. If it's going down, you're getting ahead of the curve in the resuscitation. If it's going up, you're not giving enough fluids. So it's really important we get a baseline and then use that as a tracking tool to see whether we're adequately resuscitating the patient. These people need Foley's in so we can do INOs and check them for urine and urine culture. Remember, septic patients, it principally comes from 3 sites, sometimes 4. It's their lungs, they have pneumonia, they have a urinary tract infection, a pyelonephritis, or skin. And the 4th one are line sepsis, people who have indwelling lines. And you all know those patients, the dialysis patients, or the patients with PICC lines, central lines infiltrate. Those are the principal sources. So we want to culture anything that has to do with that. Line sepsis, blood cultures. Pneumonia, blood culture, chest x-ray. Urine infection, urine culture. Those are things we want to do on these patients. You've got to get those things started, get a chest x-ray and treat the fever. By just treating the fever, we're going to decrease some of the demands on the heart and the respiratory system. So this is what we get started on all septic patients. We in the ED can have a huge impact on the morbidity and mortality of these patients if we do these things aggressively early on and get the right antibiotic started. Antibiotic choice is up to the docs. Strokes. We will be a stroke receiving center hopefully sometime this year. We need to be great at stroke care. We need to suspect strokes. We need to evaluate them quickly because there are decisions that are time dependent in patients that may have a stroke. So anybody who may have a stroke, and all of you will be going through a course so that you can do an NIH stroke scale and know how to apply that. That'll be coming further down the line. It's an educational process that will be done, and you can do that online. But we all have to be certified to be able to do the NIH stroke scale. So anyway, suspected stroke, and you all know what those look like. You need to put a monitor, get O2 on them, get an Accu-Check. Again, hypoglycemia can mimic a stroke. Get an Accu-Check right away, get IV access, and do appropriate labs, get a chest x-ray, EKG, and do a CT of the head. We start with a CT ahead of these patients. Even though we know that within the first 12 hours a lot of strokes will not show up, but bleeds will show up right away, and that changes our decision making on whether or not to give TPA down the line. And you know, that's the time-dependent part of the stroke evaluation is TPA. In the old days, excuse me, you had to have onset of symptoms to TPA within 3 hours. It's now been extended to 4.5 hours. But the time moves quickly because most patients don't get to us right away. So we need to decide whether the patients are TPA candidates or not, and we need to do that very quickly in the ED. Usually they want that done within 45 minutes of presentation. So these are things that we get started on suspected stroke patients. Testicular pain. The worst, what we do in emergency medicine, what way all emergency docs are trained, I think most nurses now have learned to do this, is we think worst first, right? What's the worst thing this could be? With testicular pain, it's a testicular torsion. Okay? Testicular torsion can happen in newborns, infants, children, and adults. Causes bad pain, but a lot of other things cause bad testicular pain. But the one that's time dependent is testicular torsion, and basically you have to get a torsion detorsed in under 6 hours or the testicle will die. So testicular pain, you need to notify the doc right away, get a urine, and get a testicular ultrasound. That's a diagnostic test. We need to get that done quickly, knowing that the clock is running there. And obviously if they're in pain, we're going to treat the pain as well. Vaginal bleeding. Some of us feel like we're a tertiary referral center for vaginal bleeding. We see as much of this as almost anything. Vaginal bleeding in the non-pregnant patient. You're going to do the pregnancy test to start with. Get an H&H to see if they've lost a significant amount of blood. And if they're bleeding heavily, you got 2 large bore IVs, just like a trauma patient, and start giving them fluids, 1 liter wide open. If they're in pain, you can give them severe pain as long as they're not shocky. If they're shocky, don't give them pain protocol until you talk to the doc. And you want to do a pregnancy test on all these patients. If they're vaginal bleeding and pregnant, what's worse first on these patients? You're worried about an ectopic pregnancy, right? So you're worried about that. They have pain or severe pain. They're bleeding heavily. They're early in their pregnancy, usually within the first 8-9 weeks. Those are the patients that may have an ectopic pregnancy. You've got to get the doc involved, particularly if they're hypotensive. They need to have bedside ultrasound done. The patient should not leave the department. Fluids are given to resuscitate, but 2 large bore IVs. I think there's confusion about what large bore IVs mean. I see a lot of nurses, when I order that, start at 20 gauge IV. That's not a large bore. It's either 16 or 18 gauge in somebody who's in shock. You need to be able to give fluids quickly. Through a 16 gauge IV, you can give fluids faster than you can with a typical triple lumen subclavian central line. So 2 large bore IVs. If you don't feel comfortable with 16, put 18s in. They need fluids, and you may need to get blood in a hurry. And our last one is weak and dizzy. I don't have a whole lot to say about weak and dizzy. Very common complaint. And weak and dizzy can be almost anything in the ED. You're going to Accu-Check these patients, get labs started, get an EKG and monitoring, and if you think they're hypotensive, you can start fluids on them, but get the physician involved. And it may be simple vestibulitis or peripheral vertigo or something like that. But that can also, weak and dizzy, we all know the 80-year-old weak and dizzy, that's an acute MI, or it's a stroke or something like that. So think worst first, be prepared for it, and get those things started. So just a few additional comments. We went through a lot of this quickly. We'll have some sort of format so you can ask additional questions online that we can answer them. But these are nurse-initiated protocols. The idea is we're going to try to keep our departments as efficient as possible. From previous experience, we know that it takes 1 or 2 docs to give you a hard time about starting these protocols, and you quit doing it. Please don't quit doing it if a doc gives you a hard time. Any feedback from a doc should be educational on this. Hey, we don't need this test in this circumstance, or we do need it, or you want to consider it. That's education. If they're giving you a hard time about it, I need to know the name of that doc. I don't want docs sabotaging this process. This is important whether it's a triage, whether it's a nurse starting an IV and drawing the blood, or initiating these protocols. These have all gone through Emergency Medicine Committee. They're approved by the Medical Executive Committee of the hospital. We think they're medically sound and evidence-based, and they will make our ED more efficient and safe, and get our patients through the system much more quickly. So we shouldn't have anybody who's giving you any negative feedback on this. Let me know if you do.